I'm here to start the presentation on another, really a sister study for those of you who were here yesterday morning in regards to family planning integration with aging care and treatment services. I'm going to be starting the presentation on a cluster-randomized controlled trial of antenatal care and HIV treatment integration, also conducted in rural Kenya and Uganda. There's going to be 4 panel presentations. One looking at the effects of antenatal care and HIV service integration on the prevention of mother-to-child transmission cascade. Secondly, we're going to be looking at that same intervention on the vertical transmission rates and also maternal outcomes. And thirdly, we're going to be looking at an assessment of integration of HIV services, antenatal care. We'll look across the facilities. And lastly, we've been hearing a lot about how stigma, the promise of integration in regards to potentially stigma reduction. And we're going to be hearing specifically about how the relationship between integration of these services and stigma are related. This study also is conducted in Nyanza province, where Family AIDS Care and Education Services operates. This study is conducted in 3 districts in Nyanza. The study was conducted in collaboration with Family AIDS Care and Education Services, or FACES, a collaboration between the Kenya Medical Research Institute, University of California, and San Francisco, and a very close partnership with the Ministries of Health. FACES is predominantly a PEPFAR-funded program, and it also serves as a very important foundation for doing clinical and implementation research. FACES predominantly provides care and treatment to over 120,000 women, men, and children in Western Kenya. It also has 2 sites in Nairobi, and also provides prevention services.
Good morning, everyone.
Good morning.
Let me try that again. Good morning, everyone.
Good morning.
Better. Okay, I'd like to start by just stating what the problem is. PMTCT is a complex health intervention in which we expect women to follow a complex series of steps in order to prevent transmission to her child and to safeguard her health. By our count, there are at least 11 steps in the PMTCT cascade. First, a woman must come to clinic, and once there, she must at least be offered and accept HIV testing. Once accepting HIV testing, if she tests positive, we ask that she get her blood drawn for CD4 count, be given ARVs to take during pregnancy, at delivery, and to administer to her infant. And we hope then that she actually swallows them and gives them to her child. We also hope that she comes for a skilled delivery, and at some point in the intervention, we hope that she gets enrolled in HIV care and treatment for her own health and well-being, and also that she then brings her child for infant testing. And finally, we hope that she is given counseling on family planning and potentially elects a method. It has been well demonstrated that in each step of this cascade, there's drop-offs in patients following each step. And in fact, there's increasing evidence that women who don't even attend ANC may have a higher rate of HIV altogether. Truth be told, a minority of patients actually complete the entire cascade. So when we conceived of this study in 2005, the majority of ANC services and HIV services were offered separately. Often, separate buildings were erected in same clinic facilities to house expanded HIV services. Pregnant women were often tested in ANC and then referred to the HIV clinic for care and treatment if they were seroreactive, as well as for PMTCT. Therefore, pregnant women were then asked to seek care in 2 places. They would have twice the visits, twice the queues, twice the laboratory evaluations. And so, not surprising, we began to wonder whether there were missed opportunities or inefficiencies in the system. Over time, program managers and policymakers recognized that potentially we could integrate these services. So together, in 2005, over many discussions, we thought of doing a cluster-randomized control trial to evaluate whether or not integration could potentially increase uptake of PMTC services, reduce mother-to-child transmission. Could it create more timely enrollment in HIV care? Could result in better adherence, better maternal health outcomes, and finally, could it reduce stigma? So I'd like to first emphasize that this is an operational study. What that means is it's a real-world study conducted under real-world conditions. We used Ministry of Health facilities, staff, supplies, and protocols. That means we didn't have study-specific staff at each facility. We didn't have study data quality teams at each facility. And so bear in mind that our results reflect all the usual challenges experienced in public health clinics, such as understaffing, high staff turnover, long patient queues, potentially supply chain shortages, or laboratory management challenges. We did this intentionally in our study design in order to evaluate the impact of our intervention in a real-world setting instead of in a controlled clinical trial setting. So we prospectively identified 12 Ministry of Health facilities in 3 districts and randomized them to receive either integrated ANC and HIV care or referral-based model of care. We worked at all 4 levels of care, including district hospitals, sub-district hospitals, health centers, and dispensaries. The major outcomes that we chose to look at were vertical transmission of HIV, uptake of infant HIV testing, linkage and retention in care for mother-infant pairs, and maternal health outcomes as measured by changes in WHO staging or CD4 count. This is a picture of one of the classic study facilities in which we can see 2 clinics, the ANC clinic and the HIV clinic, housed in separate buildings. In the control clinics, women were offered focused antenatal care, and they were offered PMTCT, which in the majority of sites were option A. They were then, once given PMTCT, referred to the HIV clinic for HIV care and treatment and long-term management. In the intervention clinics, we offered PMTCT, HIV care and treatment, and focused antenatal care. This included HAART for eligible women, opportunist infection prophylaxis and treatment, as well as laboratory monitoring and food by prescription if this was required. Only after breastfeeding cessation and early infant diagnosis was completed, at 18 months postpartum, mothers were transferred to the HIV clinic. All of these services, I might mention, were offered by the same provider within the ANC. Just briefly, I showed a schematic to illustrate that in order to account for various levels of facility, we stratified facilities by low volume, such as health center and dispensary, and high volume, such as sub-district and district hospitals, prior to randomization in order to ensure a balance of facility size. We analyzed baseline characteristics of women in the intervention and control groups to evaluate for adequate randomization. We used regression methods to evaluate for differences, and we performed Kaplan-Meier survival analyses and time-to-event analyses for outcomes. All of our comparisons take into account clustering effects. So I'd like to go over now the following 2 slides, which show patient characteristics at enrollment. The mean age at enrollment was 25. There were no differences in educational status or marital status across intervention or control sites. The same median gravida and parity was observed in both groups. The mean gestational age at enrollment was around 25 to 26 weeks in both arms of the study, and there was no statistically significant difference in WHO stage, or baseline CD4 count, or HAART eligibility across intervention or control groups. Therefore, based on our initial analysis, it appears that our 2 groups were adequately randomized and thus comparable. These baseline studies were recently published in PLOS One this past week. I'll now hand the mic over to Dr. Turan, who will go over the effects of this study on the PMTCT cascade utilization.
Thank you very much. Good morning, everyone. So now we're going to talk about how the PMTCT cascade service uptake outcomes may have differed between the 2 arms of this study. So again, we're looking at this PMTCT cascade where we often see significant drop-offs at every single stage. And we've been able to look at a variety of these service utilization outcomes in the study. I'm only going to be able to present some of them to you today. So first, what about the initial services when women came either to a fully integrated or a non-integrated antenatal care clinic? And we can see here, did women get a baseline CD4 count? And you can see here that in our fully integrated intervention clinics, 58% of women got a baseline CD4 count compared to 54% in the control clinics. Both dismayingly low, actually, in both arms of the study, and an odds ratio of 1.15 that is not statistically significant. Similarly, when women came at that first visit, they were identified as HIV positive. Were they given antiretroviral drugs for prevention of mother-to-child transmission? And we can see here that this was actually very high in both arms of the study. 93% of women in intervention clinics, 96% of women in control clinics were given these drugs for PMTCT. Whether they use them and adhere to them or not is a different question. So at least the drugs were getting out to the women. Now here in invasive supported sites, Ministry of Health sites, we hope that all HIV positive pregnant women will enroll in HIV care and treatment, not just those who have low CD4 counts, because there's a full range of services that they need to receive: OI prophylaxis, adherence counseling, support groups, etc. So when we look at our two study arms, you can see that by the end of the follow-up period, which was 1 year after enrollment in the study for our women, 69% of women in the intervention clinics had enrolled in HIV care and treatment, compared to only 36% in the control arms. Now, this was an odds ratio of 2.7, but in the adjusted analyses adjusted for clustering was actually not statistically significant. However, when we look at median time to enrollment in HIV care among those women who did enroll, the median time to enrollment was 0 days, or immediately, in the intervention arm, compared to a median of 8 days in the control arm, and that is a statistically significant hazard ratio of 2.2. When we also looked at we started to look at retention in care among women who did enroll in HIV care and treatment. And you can see here the proportions of women who had had at least 2 HIV care follow-up visits in the 6 months following their enrollment. And you can see that 64% in fully integrated sites compared to 56% in non-integrated sites. Again, not a statistically significant difference. When we look at adherence to ARBs during pregnancy, and these data are from self-report data from women that were collected after the birth, either when they came back to have a postpartum visit or when health workers went to trace them in their homes if they had not come back. And here you can see that 80% of women who had attended integrated sites reported that they did use ARBs for PMTCT during pregnancy, compared to 66% of women in the control arm. And that is a significant odds ratio of 3.53. Similarly, self-report data from women, we looked at the proportion of women who delivered in a health facility. And you can see that in the fully integrated site arm, 41% of women reported that they delivered their baby in a health facility, which is somewhat higher than the rate that we have for rural Nyanza as a whole. Whereas in the control arm, it was 34%, which is very similar to the rural Nyanza rates currently. But this was not a statistically significant difference. Finally, we looked at infant testing uptake. And so in terms of early infant diagnosis, by 12 weeks of life, you can see that in both arms, the uptake of infant testing was actually quite low. 37% in the intervention sites and 31% in the control sites, not statistically significant. I want to point out that, this study was carried out between 2009 and 2012 when the follow-up ended, just so you know the time frame. And by close of study, where the infants in both arms were an average of around 9 months of age, we had 67% of infants had been tested in the intervention arm, controlled to 56, compared to 56 in the control arm, and not statistically significant. So, in conclusion, we'll talk more about our overall conclusions when we finish the panel, but it appeared that initial services received by pregnant women at the ANC were similar in both study arms. So even though there was a lot more emphasis on HIV in the intervention arm, still those services seem to be similar. Where we did see significant effects are in women's timely enrollment in HIV care and treatment, and on their reported use of ARVs during pregnancy. And as you notice, we have trends toward positive effects on other PMTCT uptake outcomes, but not statistically significant. And you can see that early infant diagnosis and later infant diagnosis remain a challenge in both arms of our study. So I think now I'm going to turn it over to Dr. Sierra Washington again so she can present the data on maternal and child health outcomes.
Hi again. So I'm going to take the next few minutes to summarize the effects of integration on maternal heart initiation, as well as maternal health outcomes, and most importantly, vertical transmission. So I'd just like to take a moment to review the numbers of the patients analyzed at each stage of this analysis. If you recall, there were a total of 1,172 women who were enrolled in randomized facilities. That is 569 in the intervention clinics and 603 in the control clinics. We had a total of, we had a total of 539 infants alive by the 6-week PCR test results, and only a quarter of those infants actually had test results, so 143. In the control arm, we had 106 infants with 6-week test results out of 562, also only a quarter. This reflects the programmatic nature of our study, and so we decided to extend the analysis to the end of study close, which is on average 9 months of infant age. And by that time, at study close, we had 382 infant test results in the intervention arm, which is around 70%, and we had 338 infant test results in the control arm, which is around 56%. So first, let me go over our infant study outcomes. We had a total of, as I said, 568 exposed infants in the intervention arm and 594 in the control arm. In both arms, around 58% of women reported that they exclusively breastfed. At the 6 weeks mark, 4.2% transmission rate was observed in the intervention arm compared to 6.6% in the control arm. However, this difference was not statistically significant. By the end of study close, we saw that there was 7.3% of infected infants in the intervention arm compared to 8% in the control arm, which also was not a statistically significant difference. If we look then at HIV-free survival amongst exposed infants, and we define HIV-free survival as infants who are both alive and not HIV infected, we can see that there is no difference amongst intervention and control groups. I'll turn now to discuss maternal health outcomes. When we evaluated clinical progression by WHO staging and immunological progression, we found no difference across the groups. And in a composite of clinical and immunologic progression of maternal disease, we found that there was very low progression in both arms, with only 1.8% progressing in the intervention arm and 1.2% progressing in the control arm, which was not different. We defined lost follow-up in this study if women failed to come for 6 months postpartum, and if after they failed to come, we conducted 2 home visits and were unable to find the mother. We found that there was no difference in lost follow-up rates, and there was no difference in maternal death rates. and then therefore the composite loss to follow-up and death rates were also no different. When we evaluated time to heart initiation amongst eligible women, we did note that there was faster initiation of heart amongst women who were eligible in the intervention clinics. However, you will still note that when we looked at median days to heart initiation, it was still slow in both arms, with a median time to initiation of 125 days, or almost 4 months, in the intervention arm, and 185 days, or almost 6 months, in the control arm. And I think we can all agree that that is too slow. The majority of our women enrolled in PMTCT during the 3rd trimester, and therefore even if they were eligible for heart, may not have been initiated until after the delivery. So in conclusion, we found that integration of HIV services into the ANC clinic was not actually associated with a reduced risk of MTCT. In short, there was no difference in the short-term health outcomes in integrated clinics compared to standard clinics for the mothers. However, we did find that integration of HIV services in the ANC clinic did result in earlier heart initiation for eligible patients. However, I think our data can show that potentially it could be better if we could move towards a B+ approach where we do not need to wait for CD4 results or liver function test results before initiating heart in mothers who are eligible, and therefore reducing the time to ART initiation and potentially reducing transmission. Thank you very much.
Very special thank you to Dr. Ian Askew for giving an introduction to my talk this morning. So I'm going to be talking about some specifics of our integration assessments that we conducted during this study. So as has been reiterated throughout the conference, integration is often promoted to meet multiple needs of a patient simultaneously. However, we also know that integration of HIV care and antenatal services may strain an already overburdened clinic. Specifically, it may put additional pressure on the staff, the supplies, equipment, and the training and supervision needs that the staff and clients need at the facility. So, we conducted integration assessments 3 times during the study to explore variations and the extent to which the facilities involved in the trial were implementing the fully integrated or non-integrated service model. So as we discussed in the trial, we conducted an integration assessment to assess the extent of integration, full integration including heart, into antenatal care clinics compared to referral for HIV care and treatment. We used the assessing integration methodology handbook that was shown earlier this morning, and we adapted it for our study. And I'd like to give credit to the Population Council for that tool. We conducted assessments 3 times at all 12 sites and constructed a composite score to assess the extent of integration. During the integration assessments, we documented the types of services that were offered at each health facility and the number of clients that they serve. We also assessed the number and type of healthcare providers and their training in PMTCT and HIV care and treatment for both adults and pediatrics. We were also very interested in the availability of space, equipment, medical and laboratory supplies that are necessary to provide high-quality antenatal care and HIV services within the ANC clinic. We also documented the patient flow in the clinic, describing the size of the clinic, the distance between one clinic and the other, so the distance between ANC and the HIV clinic, as well as for the referral clinics, how they actually referred clients. Was it by facilitated referral or with a referral note? So I'd like to show the results of these integration assessments. We constructed composite scores for each of the main categories. As anticipated, the non-integrated sites had lower scores due to the strengthening that was required at the integrated sites in order to provide HIV services within the ANC clinic. At the end line in March 2012, the largest difference was seen between the integrated and non-integrated clinics for the supply score, 16 versus 10.3 out of a total of 19. We found that the integrated ANC clinics were better stocked with lab supplies to measure for HIV testing, CD4 measurement, pregnancy, and hemoglobin. They were also better stocked with educational and documentation materials, ARVs, treatment for opportunistic infections, multivitamins, and iron. As many will notice, many of these supplies are needed both in the ANC clinic and at the HIV clinic for ANC and PMTC2 services. However, speaking with some of the providers at the clinic and the study team, the staff at the integrated sites appeared to have more ownership over their clients because they were actually providing the services, and so they were able to find the supplies that they needed either by getting them from the HIV clinic or getting them from the district reproductive health coordinators, as opposed to the non-integrated sites where they just refer the clients. They were not, they did not demand to have all the supplies that they needed in many cases. In other cases, they were well stocked. As a result, this, like I said, the staff may have taken more initiative to obtain the supplies and equipment that they needed. The fully integrated sites also had a larger percentage of staff that were clinicians that had received formal training, meaning that they had received a certificate in HIV care and treatment. In addition to looking at the trained staff, infrastructure, materials, and supplies that are necessary to provide high-quality ANC and HIV care and treatment, we also asked the clinicians and observed whether or not they provided HIV care and treatment at the same time, in the same room, and by the same provider. In the integrated clinics, we anticipated that they would say yes to all three questions. Yes, I do provide HIV care and treatment at the same time, the same room, and by the same provider as I do for the ANC services. And in the non-integrated sites, we expected them to say no, I do not provide these services at the same time, in the same room, by the same provider. As you can see with the blue bar, the responses over time were 3 or close to 3, meaning that they were in fact providing the services at the same time in the same room by the same provider. However, you'll also notice that the non-integrated sites, the median responses were closer to 1, or just above 1. Some interesting anecdotal evidence that we've received about the explanation of why they did not adhere to their integration model is that some of these small facilities where we worked, they may have only had one staff that is dispensary, and so rather than the same nurse who's working in the ANC clinic walk the client to the next room to provide the HIV care and treatment services, they often would just provide it at the same time for convenience sake. There were other variations that we observed. For example, women who were already in care and treatment and already accessing care in the HIV clinic and became pregnant. Some of those women chose to continue receiving HIV care and treatment within the ANC clinic. So our results that we presented today focus on women who are newly diagnosed and not in care. So in general, the fully integrated sites provided PMTCT, HIV care and treatment, and ANC at the same room, same time, by the same provider. However, there were some variations that we experienced and that we documented. And the non-integrated clinics generally refer their clients for HIV care and treatment, with some exceptions, of course. We found that the variation existed depending on the availability of trained staff and staff turnover. This is one of the reasons why the non-integrated, the models, we always had to keep reinforcing the model that they've been randomized to because there was a lot of staff turnover, and this required additional training to deal with the staff turnover. But the variations also existed on the commodities and equipment, pharmacy and laboratory supplies, and the size and layout of the facility. We also noticed that primary level facilities were more likely to share staff, supplies, equipment than secondary and tertiary facilities. Overall, the integration assessments scores indicated that they matched their study assignment, but there was some variation. And one of the main outcomes for me is
we've already presented elsewhere, just to know that within the SHAPE trial, we did look at provider and patient perspectives on ANC HIV integration. So there was a patient satisfaction survey done where we surveyed ANC clients, be they HIV positive or negative, all clients at both integrated and non-integrated sites. And what we found that was among HIV-infected women, 79% of women who were attending the fully integrated clinics were very satisfied with their clinic visit, compared to only 54% of HIV-positive women who attended non-integrated clinics. And that was a statistically significant difference. But we also were concerned about what about HIV-negative women who are actually the majority of clients at these sites? Does integration reduce their satisfaction? Because they have to wait longer, potentially, all sorts of things. But we found that there was no difference for the HIV-negative women between the integrated and non-integrated sites. So basically, it looked like integration significantly increases satisfaction for HIV-positive women without having a negative impact on satisfaction for HIV-negative women. And this was published in AIDS Care earlier this year. In terms of providers, we also did a study among providers relatively early in the study after they had been trained in their randomized service models. And generally, we found that the providers were very supportive of the concept of integration in general, and they predicted a lot of important benefits. They decreased patient time, increased efficiency, closer relationships between providers and patients, and better adherence among women. But they were considerably worried about increased workload and potentially about effects on disclosure. They worried that if women's HIV status was kept completely confidential in the ANC clinic, that they wouldn't be disclosing to their partners and families and causing additional lack of support in those areas. So that was also published in Global Public Health earlier this year. So now I'm going to turn to the issue of stigma, and I know it's something that's been mentioned so much in this conference, and there's a big hope and assumption that integration will really result in reduced experiences of stigma for clients. And we didn't, as you can see, we didn't include this as a primary outcome in the trial, but fortunately we have another study that was conducted in many of the same sites that look specifically at some of these issues. So the MAMA study is the Maternity, Mammary, and AIDS Stigma study. And this is a study where we looked specifically at how women's fears and experiences of stigma can affect their use of essential both maternity and HIV services. And this was funded by NIMH US. So again, stigma and discrimination are well-recognized barriers to pregnant women's uptake of HIV services, uptake of testing, adherence. There's a lot of literature out now that support this relationship. And we wondered, does integrating HIV care and treatment into antenatal care clinics result in fewer experiences and fears of stigma for HIV-positive pregnant women, and might that actually facilitate their engagement in care? So the MAMA study is a 5-year study, and it has several components. The data that I'm going to present today are from the quantitative perspective portion of the study, where we recruited women attending antenatal care clinics. 5 of them were integrated sites from the SHAPE trial, 4 of them were non-integrated. And we recruited women at their first ANC visit of the pregnancy, and we recruited specifically women who did not know their current HIV status at the time of that first visit. And then for long-term follow-up, we selected a subsample. All the HIV-positive women were selected and a random sample of HIV-negative women. And we followed them through pregnancy and after the birth, and we were able to locate and interview around 70% of those who were selected postpartum. Just briefly, some of the other phases of MAMAs that other sources of data that we have to look at include qualitative interviews pregnant women, male partners, traditional birth attendants, and health workers. We also have done some specific intervention development qualitative work with HIV-positive pregnant women and their male partners. And finally, we just completed a survey of health workers to look at their perspectives on stigma and discrimination in the healthcare setting. Published the results that pregnant women who had higher perceptions of HIV-related stigma at baseline, so perceptions of stigma out in the community and have negative attitudes about people living with HIV, were half as likely to give birth in a health facility after adjusting again for other important predictors of health facility delivery. So we see that we have some evidence there. Now, what I want to talk about a little today is in the postpartum interviews, we were able to ask those women who did test HIV positive, have you actually experienced stigma and discrimination? And so these were 156 HIV positive women that were in our postpartum sample. And you can see that overall 61% of women reported that they had experienced some sort of stigma. And we of course have a complex measures of stigma that look at different types. And interestingly, I was somewhat surprised that actual experiences of discrimination from the community were rarely reported by these women. You may think even a little bit is actually very bad, but only 5% reported social isolation, only 9% reported fear that they were treated badly because people were afraid of being infected by them, 4% reported verbal abuse from the community, and 12% reported work-related discrimination. But the majority of this 61%, 51%, that is actually what we call self-stigma or internalized stigma. And these are the items that we use to measure self-stigma. So things like, because of their HIV status, I felt completely worthless. I felt ashamed of having this disease. I felt that I'm no longer a person. I felt that I brought a lot of trouble to my family. And I felt that I did not deserve to live. So these are pretty sad statements. But 51% of the women in the sample had some degree of this self-stigma. And so when we looked at that, because we focused on that because that was the majority of what women reported. So when we looked at it by integration status at the site, 40% of women who attended integrated clinics reported some self-stigma, compared to 62% of women who attended non-integrated clinics. And when you look at just a simple chi-square analysis, that looks like a pretty big difference, right? But again, after we adjusted for clustering, it's not statistically significant. But the finding that I want to bring out is that we found that in both integrated and non-integrated settings, self-stigma was a significant barrier to enrollment in HIV care and treatment. So we found in both types of settings, women who experienced higher levels of self-stigma were much less likely to enroll in HIV care than other women. So we did a stratified analysis looking at the two types of sites. So basically from these findings, we can say that HIV-related stigma was a significant barrier to pregnant women's engagement in HIV care, and that integration of ANC and HIV services may play a role in reducing experiences of stigma, but it's a little bit unclear because of probably the clustering, of similar experiences within the sites. However, we did find that internalized stigma continued to be an important barrier for some women at both integrated and non-integrated clinics. And to me, this really argues that we have to integrate stigma reduction interventions into ANC and HIV services in order for women to achieve the full benefits of integration. So I'd be happy to discuss this more later, but this is my argument is that integration is not enough. So we'll get to that in the discussion section. So I'm going to continue a little bit now here to give a few overviews and summing up statements. out some of the limitations of the SHAPE trial. As Dr. Washington has already pointed out, this was a real-world trial, and the only sources of data that we really had to rely on were often very incomplete medical records and the registers as the sites. These were our data sources, and we struggled. Then there were issues that just the struggles that sites go through, any kind of health facility with insufficient staffing, lack of supplies. So this happened during the course of the study and affected the quality of care in both arms of the study. Including the fact that often the sites did not have the adequate systems for obtaining baseline and follow-up CD4 counts for the pregnant women involved in our study. So we didn't have those outcomes. Our study took a little bit longer to take than we had initially proposed, which kind of drew out the whole period for this whole thing. I mean, partially because the HIV prevalence was a little bit less than when we first wrote the protocol, which is a good thing, I guess. And that a lot of people were already on care. Other limitations is this is a relatively small number of sites for a cluster randomized trial. 12 is a small size. And so we had only 12 sites, and just the realities of loss to follow-up in the PMTCT cascade meant that we had reduced power to detect effects between the study arms for some of our most important outcomes. And finally, demonstration of cost effectiveness was not included in the design of this trial. We recognize the importance. That was not part of the initial study design. So I think, of course, these are the follow-up data collection has finished within just a few months ago, and we're continuing to look at these data and analyze them and examine them, and we're going to be, of course, publishing and disseminating this information. But I wanted to throw out some thoughts and questions that I hope that we'll be able to discuss here or maybe later is, thinking about, okay, how do these data fit into the existing data that we have about ANC and HIV integration? And basically, I think this trial, a randomized controlled trial, has confirmed some of the results that we've seen from some other types of study designs on effects of timely enrollment in HIV care and timely initiation of HART, or quicker initiation of HART in integration sites. But I'd like to hear some other thoughts. The other question that we sort of thought for the group is, so, how can we really take the best advantage of these operations, research, and implementation science studies, given the challenges that we have with data quality and collection and regular medical record systems at the sites that we're working at, and how do we do that? And finally, what are the policy implications of these results, both for Kenya and other sites? And I think, for me, the main take-home message is that integration can have important benefits in improving service uptake for women and infants, but that integration is not enough, and that we need to look at the demand side barriers in women's lives that prevent them from being able to adequately take advantage of these services. But I'd also like to hear from the group other thoughts. So maybe I'll just quickly do acknowledgments before we open up for questions. Okay. So of course these studies are a huge team of people that make amazing contributions throughout the study, and these are just some pictures of the clinic and community health assistants who work at the sites, and especially for the MAMA studies, were directly involved in data collection. And so we have to thank all of our study participants in the Migori, Rango, and Niatiki districts. We have to thank the great support of FACE's leadership and staff. This is really a joint effort. And the support of the Nyanza Provincial Ministries of Health, who supported us all the way. We have a big team of study coordinators. We have also a team of data analysts and the data team who worked on the medical record and register data that we were able to use. And I want to give a special recognition to Kevin Orr, who is the main statistical analyst for this trial and has done an excellent job of pulling all these results together. And finally, we have had some medical students these are some of the students who worked on the patient and provider satisfaction studies. Okay, thank you very much.
Thank you to this excellent group of speakers. In the interest of time, I think we only have 5 minutes for questions, so